Good morning and welcome to our monthly live broadcast for endovascular cases from Mount Sinai Hospital here in New York City. Happy New Year to our viewers. I'm Vishal Kapoor, your moderator. And keeping in tradition of doing some exciting cases here at Mount Sinai, spearheaded by our chief right here, Dr. Prakash Krishnan, we're excited to bring another very interesting case, which involves our star multi-specialty team, which is interventional radiology by Dr. Rahul right there, so the vascular surgery represented by Dr. Ajit Rao, and of course our own team of David Song in the team as well. And of course, you'll be joining with our right now a guest moderator who's becoming more like a normal regular moderator, Dr. Srini Tumala from Florida Vascular Associates. Morning, Srini. And soon to be joined by Dr. Raman Sharma as well. So another new calendar year, but same academic year, another very exciting case for us to present and to see how we deal with it, what are the treatment strategies, what's the thought process, and hopefully have great results. So without further ado, good morning, PK and the team.
New Year, as you introduced Rahul and Ajit and David, we've got our endovascular fellow Harsh Doshi here, as well as Ray Lascano, and as well as our wonderful nursing team. And we've got Mac here, as well as Denisa. And where is, I guess, oh, he's outside. Okay, our tech is outside as well. So Damien, so we're ready to start. And this case is a great case, and I want to just tell everybody our goals for this year. As you can see, we're working very closely with Rahul and Ajit, and really trying to show complex cases that need a lot of thought process for the interventional cardiologist. Obviously, for us, working with the IVC and complex venous systems is not something that really falls into us, or working with difficult critical limb ischemia. Again, it's not really that falls into our wheelhouse. And at Sinai here, we have the ability to tap into great talent and really work but provide the best care for our patient. So Rahul is kindly, accepted to be the main operator in this case and really show us on how to tackle this case. And this is a very symptomatic patient. So without further ado, thank you, Rahul.
Of course.
Thank you, Ajit, for being here. And Srini, thanks for making the time. And we're going to start with our case presentation, and we'll get going.
Sure. Thanks for joining us, everyone. So we'll begin with our case presentation. So we have a 62-year-old male with a history of gastric cancer, carcinoid tumor actually, history of a right atrial thrombus on Xarelto, who over the last 3 months has been having prolonged heaviness, swelling, and really unable to walk as much as he was bilaterally, and worsening over the course of the day. His CEAP class is 4 to 5, and he had a negative, arterial ultrasound workup. And despite compression stockings, offloading of the leg, and weight loss strategies, his symptoms still persisted, and it was really affecting his quality of life. And he's on Xarelto 20 milligrams daily. So like I said before, normal ABI. His echo showed that there was no, evidence of thrombus in the right atrium, which was thought to be the reason he was on Xarelto before. And as you can see from the venous ultrasound, although there was no DVT, there was a lot of deep venous reflux noted in the deep femoral venous system. So just the basic anatomy of the lower extremity veins. You have your deep and superficial veins that are connected by various perforators. In the deep system, you start with your plantar veins that connect to your posterior tibial, peroneal, and anterior tibial veins, which connect to your popliteal. Go through your superficial femoral, a common femoral, which connect to your external iliac veins, and then finally your common iliac veins into your IVC. So this is the diagnostic venogram we took when he presented to us. And as you can see, the external iliac veins dilated, as well as there's significant compression of the IVC with thrombus or post-thrombotic, appearance of the right external iliac and common iliac vein. And you can see that the patient has a lot of collaterals from the vertebral and gonadal veins as well.
Tributaries.
Tributaries, yep. And this just shows you the extent of the IVC compression all the way up to basically the entrance point of the right atrium.
And then the CAT scan.
And now we'll go through the, we actually did an IVUS at this particular time from the diagnostic. And as you can see, as the IVUS is playing, you'll see this is your IVC, and then it's pretty much immediately compressed externally. And the compression basically goes all the way down to your external iliac. And so this is the CT venogram that we did. I'll just play it for you guys.
And Rahul, maybe you can read it for them and see what your thoughts are.
Yeah, so you can see the sort of post-surgical changes. He has fluid in his belly, which is probably related to like an SMV occlusion from the previous tumor. The IVC, you don't really see the IVC. It's either a cord or there's not much there. You can see the iliac veins are dilated, but they're not really filling very well just because they're just under high pressure and the contrast hasn't gotten there yet. But it sort of confirms what you guys saw on the venogram. But there's basically no mass, no tumor really compressing it.
Nothing compressing.
Yeah, it's just probably related to his previous treatment. I don't know if he got radiation at some point or something like that, but it just related to the previous tumor treatment.
So he had a right atrial clot, which is now resolved on Xarelto. It's gone.
Right.
So the idea here is now we're going to go. How would you approach this? I mean, any surgical options here, Ajit? I mean, in these kind of patients.
Yeah, I mean, I think that's a great question. I think for these, it's primarily endovascular first. Operating on the IVC is pretty high risk. The patency, isn't really. It's not like you get a increased benefit or anything compared to like the leg when we talk about bypass versus stenting. So I think my approach is always endovascular first to treat these IVC, iliac vein stenoses or occlusions.
And Rahul and Ajit, do you guys use stent grafts for these kind of things, or is it standard stents? I know you were part of a major trial.
Yeah, so the two stents that are FDA approved that are available in the U.S. are the Medtronic and the Bard stents. They can both argue which one's better, but basically the data is around the same. They both go up to about 20 millimeters in diameter, and they have good lengths, and they're good venous stents. There's a third stent that I think the trial just completed for the IVC side, which is the Gore stent. That one it's a good stent. We're still waiting to see what the data shows, but that one will go up to 28 millimeters.
Wow.
And when you actually hold the stent, it has a lot of radial strength. So it allows you to also then do different configurations of stenting within the IVC. Like you can basically put like what it looks like a tube graft right into the IVC to get sort of a 28 millimeter IVC if you needed to, and then you can double barrel into that. That's sort of going to be the question: is how do you stent this?
Exactly, and I think that's the challenge here. How do you size?
Yeah.
How do you stent? Where do you land the stent? And how far do you extend the stent?
Right.
I think those are sort of the questions.
Yeah.
So you're going to start with an IVUS? You want to go ahead?
So I think first thing we have to probably just cross everything.
035?
Yeah.
All right. So just to give us a
Get
brief
us a
idea,
supercore,
PK,
guys.
what do we have in there from Access to begin with, just from a technical perspective?
So what we did was we put in two 10 French sheaths, and we've got a pigtail up in the atrium, as you can see. We're giving them a supercore wire over which we're going to put a 10 French IVUS in. Once we get a 10 French IVUS, we're going to go ahead and IVUS this, so this way we can assess it and get their thoughts on how to do this.
Right.
So intuitively you would say, oh, let's just balloon stent this, but obviously there's a lot of nuances that go into this particular type of decision being made. I mean, what size balloon do you use? How do you size it? I mean, what are the anatomic landmarks you're looking for in IVUS to say, okay, well, this is the size of my thing. I don't know whether the value of CT, as you saw, Dr. Patel was saying, the CT really didn't show much, and it's very difficult to actually say how big the IVC is. So I think there's a lot of challenges in this particular type of case. And you can see here, just crossing into the atrium is very difficult as well. So it's going to be an interesting situation. As far as anticoagulation, we've given heparin. So how much heparin did we give, David?
We gave 8,000. ACT is cooking. What's it at?
So 8,000 units of heparin to start, and then ACT is cooking.
Great. I'm just going to get Dr. Tumala's opinion, being an interventional radiologist, and him also dealing with complex cases like Rahul. Srini, your thoughts on this case, the presentation? I know complexity, decision making. How would you approach this on an overall perspective?
Yeah, no. Can you guys hear me okay now?
Yes, perfect. Yes.
Good. Okay, good. No, I mean, looking at this, the first thing I thought of was that is there some level of extrinsic compression, and that's what I think Rahul was talking about, and I was like, let's look at the CT, and I think it was the two good things in this. One is the intrahepatic IVC did not look involved, and I think Rahul would agree. I mean, it looked like it was decompressed because it just doesn't have good inflow. but it's not involved. That's a much more complex reconstruction when you have to worry about the intrahepatic inferior vena cava. The second thing is, you know that segment within the liver is narrowed because if you notice, there's edema on the soft tissues in addition to ascites. You're less likely to see that when your stenosis or occlusion is infrarenal. So that's the second point. I think the third point is, where are the renal veins and, do we have to cross those and cover them? I mean, I know we all have in the past when we've dealt with these types of reconstructions. I think we're assuming the etiology.
Catheters, yeah, up there.
Is it short? Or, no, there it is.
Something related to the carcinoid.
What's the length of this IVC, this catheter?
No, there it is. It's just
100.
Right. No,
It's just
I
doubled over.
completely
Yeah, it's
agree with
doubled
you.
over.
From a learning perspective, what
there
are
it
the,
is,
I mean, every vessel is important and every vessel we want to preserve, but from a learning perspective, especially when you start deploying these stents, these
Trying to get it
covered
up into the-
stents,
What's that?
what
Trying to
real
get it into
veins
the,
are we looking on
SVC
as
or something.
markers to avoid or to involve, not to involve, stay away from it? Any specific guidance on that?
I mean, ideally, you want to be very
branch.
covered stents in general. Most people are not using.
Looks like he's in the heart because you're getting PVCs.
Yeah, no, just trying to get it out into. Go ahead,
Unless there's
Jimmy,
a
sorry.
risk for perforation, and then they'll think about it. But that's number one. I think number two is trying to stay out of the liver if you don't need to be stenting into the intrahepatic IVC. The third is if you don't have to stent across the renals, try to avoid it.
Yes.
Although
Yeah.
we've done it in the
Huh,
I think
Can you give us
fourth
some
thing to
contrast?
look at to make sure you look at the inflow. What is the status of the funda, the common
Damien, we
funda?
need contrast.
The inflow is what's going to help you with your long-term patency here when you're
Patency.
done.
There you go, brother.
Great.
So-
I mean,
so-
amazing points. Yes.
We're trying to cross into the SVC, obviously, here. And, with a little bit of, obviously, tortuosity, occlusion, difficult to manipulate. So I think Rahul's just going to take a shot here and decide where we are.
Yeah, we're in the SVC, but I don't know if we saw if he had an SVC occlusion on top of whatever else he had.
Oh, geez.
So, but that's okay. Part of the point, like
That
when
would be
we
fitting.
Yeah, what we teach our fellows or trainees or anyone who's really doing this is that, you also, whenever you do these, even though this one it may be a little bit more straightforward, is you have to plan for the worst. And obviously the worst thing you can have happen here when you put in a venous stent is have it fly.
Right.
And so if you have the wire someplace where it's like pinned up like this, or if it's buried into the
Right.
brachiocephalic vein, if it does fly, you're still on the
IVUS.
wire, you can always put a balloon through it and try to pull it back down.
Right.
So, just to leave it floating in the RA, it theoretically could slide right off and into other problems. So, yeah.
Well, yeah, even with our just, May Turner stents, we
Yeah.
always tell them same
Yeah.
thing.
Yeah.
I think it's very important, but that's a great technical point.
Yeah.
So Ajit, can you mention? I know you mentioned the renal veins as well. I mean, what is the importance there, guys? I know you guys are saying this for the cardiologist who doesn't understand this aspect. What should they know about this?
Yeah, I mean, I think, ideally you'd want to, I think for this case, the important parts are just your endpoints. So like we talked about the iliac, making sure you land somewhere healthy for the inflow, but then even the end of the stent proximally, in the IVC is important, making sure you're not landing it in a compressed zone. So we'll have to take a good venogram and IVUS to decide where that is, but in an ideal world, I would try to land it below the renal veins. That being said, sometimes you don't have that option, and I have done a bare metal, stent across the renal veins, but it's very rare, and I would prefer not to. Sometimes when we do open surgery, we actually ligate the renal vein,
Right.
and so it's not, it's not like they'll definitely go into renal failure if you lose the renal vein. But again, I think good practice is to try to preserve it, at all costs if you can.
Can we go with the IVUS live, please? IVUS live now on the screen here, so Dr. Rahul can talk about the IVUS. All right, go live, guys. IVUS, thank you.
Yeah, so
perfect.
we have the Philips 035 IVUS up, just into the suprahepatic IVC. You can see if I go up a little bit, we're getting into the right atrium right there. And then what we're going to do is we're just going to sort of pull back and hopefully...
Record, guys. Thank you.
Cool. So the suprahepatic IVC is okay, right? And then you get into the intrahepatic IVC. It's already starting to get narrowed there.
Yeah.
It's kind of crushed. And then we're coming back down.
So we have no lumen, really. Very, very like a
No,
pancake
it comes
lumen.
up right there.
Yeah, it's still...
very, very tight. Can't even see the renal veins, really, huh?
Yeah, and so, to Ajit's point about the renal veins, ideally, you would like to not have to cover them. Here we just come down and we'll eventually get into the, we're here with the common iliac on the right.
Right there.
Which actually looks pretty normal. there. So, ideally, we would like to not have to cover the renal veins, but I think here we're going to
walk it off here?
yeah, we're going to get forced into it. There is data to show, actually, with the 3 stents that are currently on the market, including the wall stent. So I always forget about the wall stent. But the wall stent as well, if you cover the renal veins, it doesn't really affect renal function or patency, renal vein patency. But that being said, from an aesthetic standpoint, it's always nice to stay stay below it.
So in terms of sizing now you've got a CAT scan that shows collapse. So how are you sizing this? Do you balloon it? What are your thoughts?
So we know we can at least, again, sort of like when you cross an SFA, you got to make sure whatever device you're going to put up when you put the stent up, you're going to at least have a lumen so you can get back through to put the balloon back up, right? So you don't want to end up stuck like that. So we should probably pre-dilate. I don't think you need to take it to like 20.
That's what I was going to ask you.
But maybe just take it to 10 just to see, get a lumen and get a sense of what's going on.
10 millimeter balloon, please,
So,
long.
Rahul, just to go back onto the IVUS to comment, the nature of the intrahepatic IVC, do you think it's, you didn't see much of a thrombotic component. You just saw merely a collapse, but not like fibrotic, post-thrombotic kind of a feature of how the vein usually looks, especially after so-called the DVT or whatever, IVC, DVT, one you can call it?
Yeah, so it looks compressed. So the question is then, ideally you'd like to build your stent column
80's fine.
From the top down, right? So the question is, do you put a 20 millimeter stent first in the infrarenal IVC and then see what the suprarenal IVC looks like? Maybe once we balloon a little bit, get some more inflow, maybe that will help a little bit. And sort of help make our decision to exactly say where we're going to start our stent column from. Do we have to go all the way up to the right atrium, or can we bring it down?
So sure. Ajit, you with stent grafts. Now that we have these larger stents available, is there a role for stent grafts, or is it only for bailout with rupture now?
My algorithm is pretty much bailout. I think number one, it's a cost issue because if you're putting in a large stent graft, you're talking about a TVAR device, which is a lot more expensive than any venous stent. And also, I don't think it's necessary. I think there's good data on the the on-label stents we have, the Abre, the Bard stent, that they work pretty well. So my algorithm is to go with a venous stent, and then I've very rarely had to put in like a large TVAR into the IVC, and that's usually in the setting of a IVC filter removal with like a rupture that didn't stop with a prolonged balloon. So yeah, I almost always never use a stent graft.
Okay.
We'll just start there, right?
So we're going with a 10 millimeter balloon. So we have a 10 millimeter balloon, guys. 80 millimeter length by 10, and going up slow here. Yep.
So, Srini brought up a point regarding the intrahepatic IVC involvement versus not. So, can you speak a little bit more about, I guess, what to expect post-procedurally for these patients? What would happen if they do have more of the hepatic?
So it really depends. So it really depends if they have involvement of the hepatic vein outflow, right? So it's really that suprahepatic IVC, the hepatic veins. So actually, at one point, the wire flipped into the hepatic vein, which isn't uncommon.
So this is 10 millimeters.
You end up with basically with Budd Chiari, right? So what we call membranous.
You want to go to nominal, right?
Yeah.
Go to 8.
Yeah, you go to 10.
6 is nominal.
6 then.
Yeah, that's fine.
Perfect.
Yeah. So really no waste there. So so then you can end up with Budd Chiari, which basically gives you prehepatic portal hypertension and then gives you ascites. I don't think that's what's going on in this case, just because if you look at the CT scan, he doesn't have that sort of classic what we call nutmeg liver on CT to give you that sense of Budd Chiari or portal hypertension.
So when you're looking at the IVUS and you're like trying to see if it's a dynamic versus fixed obstruction, does that change how you prep your vessel before you stent? Or would you be more aggressive about ballooning if it's fixed, or how do you decide?
Flora, brother?
Yeah. So if it's truly compression, then I'm not so aggressive in terms of prepping the vessel because I don't think you really need to, because the stent itself will pop open the lumen.
You may be in the
So one more question from the audience, Rahul, is like based again, the question eventually, and for Srini as well, the question eventually goes on the appropriate sizing. Patient who's been NPO overnight, prone position, supine position, dehydration, all these factors, how do you account for it when you're actually sizing? I know IVUS is a good marker, but the venous system is a lot of volume dependent system and position dependent system as well, and you want to get a good sizing as well. So how do you accommodate those factors into your sizing?
So look, for IVC, frankly speaking, we just the biggest stent they have is a 20. And so we just put a 20 into the IVC because then unless it looks bigger, then you have to kind of think about putting in.
I guess the advantage of the BD stent is that the proximal end becomes
flares.
larger, right?
Yeah,
Flares up.
Yeah, so it's a 20% flare,
Cine?
which is this one.
The middle one, yeah.
So you could theoretically sit it.
Oh, well, but
But in this case, the plan is to do like a double barrel from both ends. Is
Why
that
don't we
what we're
attach
talking
this?
about?
No, attach the
Well,
injector.
so that's
Injector.
the injector. Sorry.
Yep, that's probably better. I was like, what are we doing here?
Yeah.
Well, I'm sorry. That's a great question, Vishal. I was going to ask that question to Ajit because in the back in the day, we used to put double barrel stenting before we had dedicated IVC stents, right? So I mean, what do you guys do now, Cine?
Yeah, I mean, I think it just depends where the lesion starts. So in this case, it looks like there's
Both sides.
both iliacs are,
Yeah.
common
Yeah.
iliacs are occluded or narrow. So you're going to have to do some sort of kissing stent into the IVC, and then it's just a matter if you want to do a separate IVC stent, before you do those kissing stents.
And
Like
you
a
can see
modified CRAB in the vein.
Yeah, exactly. The CRAB of the vein.
Yeah, I
I
mean,
the
want to balloon the other side?
But
Uh,
I think that's a
I
good
don't
point,
think
though,
so.
because
No,
how
right?
do you
You don't
size
need
it,
to.
right? Because you want to make sure you're sized
right.
enough for the iliac,
Although we should
but not
cross from the
oversized for
other
the
side. I mean, I guess
IVC
we gotta
since
figure
you're
out
putting in
what
two
this is.
stents until,
Exactly. That's the question arises. If the IVC is 20 and I want to
need
do
another
a
wire?
double barrel, like
Another
what
wire
we were
now,
talking
right?
about,
Uh,
how
yeah,
do we
now.
size it?
yeah.
I actually like the
Yep.
idea
Yeah.
of a venous CRAB.
Well,
Yeah.
Srini,
Actually,
what's your
it's-
thoughts on those? How would you approach it? We have to do a bilateral iliac into IVC reconstruction.
Yeah, I mean, both techniques work, whether you do a single IVC stent and then put in double barrel iliac stent, and also the double barrel technique. I mean,
What's
there's
the
enough,
next ACT?
although it's not a lot of it, there's enough data to show that both techniques work. I think
What?
it just depends what you're able to accomplish. In this case, I'd probably,
No,
I guess you
did you get more
really-
heparin last time?
The one thing I wanted to point out was that if you look at the IVC, it looks like
Mhm.
whatever area is, it's below the level of the hepatic veins. Wouldn't you agree, Rahul?
Yeah.
The
Yep.
Yeah.
That's why it looked so good up higher. So that's a positive thing. In terms of sizing, Rahul is right. There's no data on how you size these. People are going off of what a normal IVC should be. 18 to 22 millimeters, somewhere in that range. So a 20 millimeter stent makes good sense because you really need to get good luminal gain in this case.
Yeah, and the issue here is that you can do double barrel, but the question is, are you going to do double barrel all the way up to
Yeah,
the suprahepatic IVC, which just ends
Right.
up being a lot of stents.
but also in the old days, Srini, Rahul, when we didn't have the dedicated IVC stents, we used to do double, and the restenosis rates were very high.
Yeah, I mean, because for various reasons, right?
Yes.
So-
But yeah,
I think it also depends on the size of the IVC, because if you're worried that it's a large IVC and your stent in the IVC could migrate,
Correct.
I'd be more inclined to do kissing iliac stents, all
To
the way
anchor it?
up to anchor it more, so you have a
Yeah.
lower chance
That's
of
a
that
good point.
stent. So
No, but I think here with the fibrosis,
Here,
I don't think it's
it will
going to go
matter.
anywhere. I don't
Yeah.
think
yeah,
it's going to go
it's not
anywhere.
going to go anywhere. Yeah, so you just want to make sure that where you stent on the top is okay, but we'll take the longest 20 stent they have, and it'll.
So would
sit.
you go with the BD because of the flare?
Yeah,
here?
we could. I don't. I haven't found the flare to be super
Same.
useful, but it does make it look nicer. But then you also have the flare on every other stent you got too after that. So,
Right.
Yeah.
Yeah, I
So let's get a 20
It's
millimeter.
whatever.
yeah, I think
Abre?
BD, Abre, both good stents.
Go with an Abre?
Yeah. Whatever.
You have 20 length of Abre?
Is anyone still using wall stents? Is there a
So
role?
wall stents, there are some holdouts. Your partner Windsor still loves the wall stents, and look, they're good stents. The tricky part with the wall stent is you have to use them all the time because they are very finicky and user dependent
Follow up on the
stents, right?
ACT.
And they do have good radial force, but they're only radial force if you get them to the nominal size, which is really hard. And then to try to measure the lengths and everything,
20 length.
they are much
Long.
more prone to
2000 you have? 2000 is fine.
yeah, they're much more prone to fly.
Yeah, I've shied away from them just because when they have a tendency to foreshorten. So especially if you're trying to do like May Thurner where you need to land it exactly.
Yeah.
It's a
Well,
little
I
hard.
think with the newer stents, is there really a role for them? In your opinion?
So right now with what's available, if you need to go bigger than 20, then that's probably it.
Okay.
Yeah.
Mm.
Yeah.
Interesting.
Srini,
The longest you
Srini
got.
works in an OBL, so I don't know the cost difference
Oh,
between
give me
a
the
wall
150.
stent and a. And
So
I think
we have
Srini,
2150.
your choice
the
of stent,
longest?
Srini?
yeah,
2150.
150. Yeah.
So I think with
Srini
the
still up.
wall,
Yeah.
also the radial strength at the ends is weak. It's not very strong at the ends. Like centrally, it's much better. I think with the
150, right? Okay, open. 2150.
it's an open cell stent, so it's good for coagulopathy and for venous renal strength. So I don't think there's really that much of a difference between the two. Don't you think, Rahul, between Abre and
Yeah.
Stent? Yeah.
Yeah, no, I don't think there's much difference.
Give it to Ray.
I think
So-
also, one thing to think about is that the IVC bifurcation, if it's intact, I don't think it really matters which technique you use, but I think if the IVC bifurcation or confluence is involved in stricture, double barrel technique may be a little bit better in some cases because you can get good expansion at that confluence.
Sorry,
whereas that's a weakness or a rate limiting, that's a weak point with reconstruction. Right, Rahul?
Yeah,
I think that's important. Yeah.
Yeah.
So we have a 150 20 millimeter stent here. So I think it should cover the whole IVC is what I'm thinking. That's why I asked for a 150.
Yeah, so we're going to try to use a little trick here. It's basically to flour it and then try to pull it down
Okay.
to get it to cinch. I think we should be okay. We'll stay out of the bifurcation here
Yep.
on this side. So,
So this is again for those at home. I mean, this is a obviously very experienced operator, and like Srini says, Rahul always makes it look so easy. Last time we did the coiling, I got comments from the audience. Oh, that was so easy. I said, guys, you have no idea how difficult that was. So the same thing here. I mean, you can see there it's flared over there.
yep. So now I'm just
Right.
going to pull it down,
Okay.
and then so that kind of cinches it. And
So
then-
everybody saw that it kind of cinches it there. He was able to trap it, and now
Yeah.
he's now going ahead and grabbing the 150 millimeter stent.
It's a
The
great
other nice
size.
thing about
yeah.
is these stents deploy very accurately, I think.
Yeah.
Both the BD and the Abres.
Do they ever elongate, guys? In your experience, have you seen them elongate? I've never seen it. That's why.
No.
I
Not
mean,
seeing
I'm
it.
assuming like any self-expanding stent, if you
Once you
pull on them
try.
hard enough,
Yeah.
you can get them to
Elongate.
elongate.
Yeah.
Yeah. So that's a,
That's pretty good.
That's
Oh, well,
favorable. It already opened up a lot.
yeah.
You got it. Just walking it out.
Yeah. So now we need to wire up the other side, right?
So we're gonna
Yeah.
get another super call. Just take a DSA just to show everybody at home. Creatinine is normal, guys.
Normal.
Okay, Cindy.
Yep.
Yep, middle one. And there's very nice.
Nice.
Yeah.
So at least we're able to get some. Like we need another super core, guys. We
Give
have
us a new
Thank
super
you.
though.
Contrast already filling in the
Right, all right.
Yeah.
Yeah, you don't see the collaterals as much. Fills through the stent first.
Yeah.
The renal.
Shows you with,
We need to check an ACT.
You have a
Yep,
cheater?
Ray, ACT. Oh, you need a cheater? Just go right in.
Well, Vishal and team, I mean, it shows you if you look at where the stent did not expand, it looks like distal IVC
Yep,
into
cheater, guys.
the biggest
Hold on.
problem.
Yeah.
Yeah, I think you're
Big
right. I
umbrella.
think that's the real culprit, like we did on the IVUS as well. Proximity, it looked well open with not much lesion, both intra and extra. It's as how you're pulling it back into the distal IVC where all the whole pathology starts. I think you're right. The reconstruction
The
of the
Bernstein?
bilateral common iliac vein into the
Yeah.
distal
Bernstein
IVC will be
catheter,
the
please.
main determinant of the
Harsh Bernstein
long-term outcome
catheter.
of this patient as well. So I think what they're
Yeah.
trying to do is get access on both sides and see if they can barrel it.
Yeah,
the
exactly. So that's the next step, right? Exactly. So just barrel into the common iliacs and then hopefully get it to sit and then balloon and then hopefully that should
It might
fix
have also been a little underfilled up top too.
Yeah,
Right? Is that
you know,
another
and
reason
this
why?
is the thing, right?
Yeah.
So the
Oh, yeah.
question is, do you try to build from the bottom up, right? Which
Yeah.
is a little trickier to do.
Yeah.
Yeah. And it sort of goes against sort of the way. Oh, that made it easy.
It went in, huh?
Yeah.
Yeah, it looks like it flew in. That's
Yeah.
great.
Nice.
We sort of nailed the bifurcation there.
And then we can just go ahead and you would IVUS this to make sure you're in the
Yeah, we should.
Absolutely.
see
Let's
if we
get the IVUS on the other side too, guys.
Yep.
To make sure that we're within the stent. And I think this is important for the cardiologist. I mean, if you think about it, you can actually look, or even the operators who don't have as much experience as Rahul and Ajit. I mean, when it looks like you're in the stent, obviously you don't want to be behind the strut, and you don't want to reconstruct the IVC behind the strut. So it's very important. Again, I think even more than a pigtail, do an IVUS, get a clear understanding of where you are, and then take it from there.
I also like to J the wire because there's less chance that it's going to go through a strut. You know, if it's
Yeah.
J'd all the way through it.
So it's interesting. You put it in the hepatic there.
Yeah, it's fine. I just need to plant it somewhere.
All right, let's get.
But
the
it also
IVUS.
shows that like we didn't cover the hepatic veins, right?
Yeah,
Which
that's a good
again,
point.
yeah. I mean, honestly, it's not a huge deal if you do, because again, I don't know if you noticed on the venogram when we did it, you could still see the renal veins filling.
Yeah,
so
yeah,
yeah.
the right, definitely
Why?
more than that. Yes,
Yep, mhm.
that's
Yeah.
good.
So
There's enough kind of real world data at this point that the renal veins don't thrombose when you cover them in this way, and which is really
Yeah.
amazing. So
Yeah. So if you guys want to go to
So let's go IVC live. I mean, IVUS live, guys.
So this is from the left side, correct?
Left
Yeah,
side.
Yeah.
perfect.
Okay. Thank you. Go ahead.
So coming up the iliac, there's probably the bifurcation, which
Oh,
looks
right there.
pretty crappy.
Tight. Yeah.
Crappy.
Yeah, but looks like
And
we're
there's the
inside
stent.
the stent. Yeah.
Beautiful. So we are
Wow,
truly
nice.
in the stent.
Yeah. So I'm not going to go all the way up.
Yeah.
I don't
And
mean
the
to.
other
Well, that's
wire
what
you
we
can see
care.
right there. Oh,
Yeah.
Yep. So Vishal, we don't have to worry about you stenting into the behind the stent.
So then the question is, what size stents do you do here?
So now how are you
Yeah.
going to size it?
Yeah.
Now,
So this is tricky. So, what we probably should size it to is to what the size of the left common iliac vein is, right?
so let's measure the left common iliac vein. I'm sorry?
Oh, we didn't record. Can we do it again?
Oh, we got to record. Sorry.
yeah. Yeah, BK didn't call the word record, so they didn't record, I guess.
Yep, the IVUS team is sleeping. Right?
And
So
then there's
we
a
gotta
possibility
slow
of stenting behind the IVC. We don't record.
Still
All
isn't
right.
your fault.
That's true.
Let's
How about
measure
you
right
just have
there.
it with me?
Oh, that actually looks compressed there, right?
It's a little compressed, yeah.
Yeah.
So let's see. There.
There, I like that. Measure that, guys. Mark.
And I think PK, Rahul will tell you, sizing, you want to be as close to 1-to-1 as possible. It's not
Yeah.
bigger is not always better, especially in veins, because you can actually create gradients by oversizing. You create intimal injury and so forth. So 1-to-1 sizing is ideal.
But
So,
in
yeah, I
thi-
was
but in
gonna
this
ask you
case,
Mhm.
Yeah.
but in this
So
case, it's impossible because you're underfilled, and I think also with
So
the,
here you're
with the-
probably
with the
overfilled,
IVC,
right? Because
yeah, here it's overfilled. Yeah.
Yeah. So
But with the IVC, you were underfilled, so it's probably impossible to tell.
yeah.
Yeah. So what would you do now if you're thinking you're overfilled here? What size would you use?
So probably use 16s, right?
Got
Double
it.
barrel 16s. We may
That's
not
what you
take
were
it to
saying.
16.
Yeah. I think
We have 16s.
Yeah. So probably like 16 100s. I think should get us back,
Two 16-100s, guys.
should get us back to where we need to be, right?
yeah.
Yeah.
Damien, two 16-100s.
So the question really,
So-
Rahul, arises, do we, with that compressed, so-called narrowed segment of the distal stent, do you balloon dilate it first to give it a little bit of more room for the stents to go in, or it doesn't matter, or it'll reshape itself because it's a self-expanding stent,
So-
hopefully in the next 24, 48 hours?
Yeah, we'll post dilate with the balloon afterwards, but we did pre-dilate on the right side at least with the
Right.
stent, and then it looked like on the venogram when you guys did it before, it looked like the left was coming over into the right.
Absolutely.
So I think we're okay there.
Okay.
Yeah, but I agree. If it looks tight or whatever, we probably would pre-dilate.
Pre-dilate.
Yeah.
Okay,
Yeah.
great.
So the question here is, okay, now that if you establish flow, anticoagulation wise, do you put them on a NOAC? Do you put them on Coumadin? How do you guys manage them? Legit?
I do at least 1 to 3 months of Xarelto or a DOAC, and then depending on how complex of a reconstruction, decide if I need to continue it after that.
Yeah, so it depends. If you feel it's post-thrombotic, right? So then,
Well, yeah. this one.
so post-thrombotic. So usually, actually, what I'll do is I'll do a short course of Lovenox first.
Okay.
And I think there's good data to show, especially like even post-DVT intervention, that Lovenox before starting a DOAC helps because it's a little bit of anti-inflammatory. It gets them up to the right level, their anticoagulation level quickly. Some people do 2 weeks, some people do a month. I sort of just do about 2 weeks, see them in the office, get an ultrasound. If everything looks good, then we'll switch them to a DOAC.
Got it.
To a DOAC then. And then, here, he's already on a DOAC, so the question is not really a big issue because he's going to be on it anyway for
You
the
can
right,
open it.
for the right atrial thrombus. But afterwards, again, we do DOAC for 3 to 6 months. Again, I agree with the JIT, in terms of how complex the intervention was. And then, if the patient can't be on it, we've done half dose, DOAC. We've done just aspirin, just Plavix. After that, there's really no data.
So interestingly, he's been on it. His hemoglobin has been trending down.
Okay.
So we do have obviously the GI and everybody looking in on him,
Yeah.
but he needs to be on it because of that right atrial issue that he had.
Yeah.
So I think that this is going to be another challenge for him to figure out what's the right way to do it.
Yeah.
But in this patient, would you guys?
Sorry.
Go ahead,
If you guys have patients who have more of an extrinsic compression, that's not really of a true thrombotic injury, but just because of
Get the other one?
a myomatous uterus or something like
Another
that.
100? Two of them.
Does your post-procedural antithrombotic therapy change to more of an antiplatelet therapy, or do you still stick with an antithrombotic?
Yeah, that's also, it's a tough one. So like, what do you do for the nival May-Thurner lesions, right? So, I think there's data to show, on both ends that, aspirin, which is sort of voodoo at that point, or, some people do like the half dose DOAC for a period of time, depending on, some people look at like, do they impinge on the contralateral iliac and things like that. But I don't think we have good data to show what the exact appropriate pharmacologic management of these patients are post for just pure intrinsic external compression. Yeah. I don't know, what do you guys, Srini, what do you guys do for your NIVL patients? What do you recommend?
I think what Rahul is saying is right on. There's not a lot of good data. People retrospective analyses and some
16100, right?
studies and small patients. But there was a paper which is kind of best practice with some experts. It was like a consensus panel. What we do know is that inflammation is probably a big thing that we control. So a lot of people are going to Lovenox for about 2 weeks or a month, help with the get some anti-inflammatory effect there. And then if they look good at that, and some people are putting them on antiplatelet at the same time. They're doing Lovenox plus either clopidogrel or an aspirin. And then they're basically converting them to a DOAC and then still continuing some level of antiplatelet 3 months and then stopping it. But when you really call around to really busy centers, it's all over the place. And that's part of the problem with venous interventions is that we don't have a good, kind of cocktail, if you will, like we do on the arterial side, or at least better on the arterial side now, on the vein side. Now, regarding, I think when it comes to anticoagulation, the way I think about it, if the patient needs anticoagulation because of their underlying problem and issues, then we go ahead and anticoagulate. If you don't need to anticoagulate, because they've never had a DVT, thrombus, etc. In this case, obviously, this is a thrombotic case. You would anticoagulate. Then you could make the argument for Lovenox and platelet and just see how they do, and then go from there.
That's good logic.
That's the way to think about it.
But my question now is a technical question for both Rahul and Ajit. So you've got all these layers of stents. How much overlap do you need? I mean, you don't expect the bottom stent to migrate up, and now, I mean, I don't, especially with we're one-to-one sized in the external iliac vein. Yeah. So I mean, I worry about all that metal in the distal, and is that a nidus for a problem later down the road?
Yeah, I mean, I think it's definitely a concern. I think we'll have to IVUS very carefully after we post-dilate it, but I think it's kind of a trade-off, right? Because you want to be aggressive with post-dilating it so you get really good luminal expansion, but you also, the risk is you don't want to rupture because you don't know how fibrotic or scarred that is, and if it ruptures right at the bifurcation, that's a hard place to fix.
Yeah, but also the amount of metal that's going to be there. You have 3 layers now in that one area, so it's going to be kind of interesting.
So I think I think our position right now is pretty good. I think if you want to limit how much you're overlapping 3 stents, then this should be sufficient.
So you do like about 4 cell overlap, huh, Rahul?
I mean, I think it's only 1.
Is it 1?
Because these cells are really big.
Oh yeah, no, I see it now. Actually, I was looking up top. You're right. Yeah, now I do see it.
Yeah. So they're very these, at least the Medtronic and the Bard stents, they're pretty open cell.
Yep.
So the amount of metal in terms of overlap isn't actually that bad.
Right.
Yeah. As opposed to like 2 wall stents, right, which has a lot more metal there.
I want to thank Raman for not making a comment on my vision. Thank you, Raman.
Perfect. All right. Great.
And then,
so should we deploy some?
Yeah, go ahead, please. Yeah. So do you do one at a time?
No, we're gonna do them 2 together. So
all right, let's watch this, guys.
So
It'll be fun.
You're gonna do one. I'm gonna do one.
Well, you do both. You do both. Show us how you do both. It'll be fun, Flora.
You realize I have fellows, right?
Yeah. Well, that's there you go.
You just want to make sure it doesn't jump, so I guess you have to just have a little bit of control right there. Yeah, see? Right there. Perfect.
So you flare them and pull them back, is it?
So I'm not really... Yeah. I'm flaring one and then trying to get the other one to match, right?
Ah, there you go. You got it. Yeah. Perfect. You see that, guys? It was made to look easy again. There you go. Very nice. Srini, you said it last time.
Yeah, PK is he's treating Rahul like Karthik and Distal now. He's making him do all
there's no way in hell. Rahul knows that. Come on. There's no way.
All right, so I'm gonna hold these.
Ready? Okay.
You
got it.
Yeah.
Wow, very tight, huh?
Yeah. I think it's part of it's on the.
But I think that part is really important because you don't want one stent to be higher than the other because that's a reason for early failure.
There you go. So why is that a reason for early failure, guys? Let's talk a little bit about that. IVUS?
I think they can impinge kind of the outflow from the stent from the other side if one's a lot higher.
Should we balloon first?
You want a balloon first?
They are open cell stents.
Realistically,
Get us that 12040 balloon.
We need 2 of them.
Two 12-0s.
The idea makes a lot of sense, especially if the radial force is preserved equally, especially all the way towards the edge. But if these stents flare about 20% or 10 to 20%, the radial force at that distal edge is going to be less than the majority of the rest of the actual stent. So how much, I guess for the users, how much of a miss is acceptable? Would it be like half a centimeter?
2/12.
A centimeter will be really pushing it, but
Yeah,
within half a
40 and
centimeter
60 is
seems
fine.
to be reasonable, no?
yeah, it is
2/12s
reasonable. What
would
you
be
don't want
great,
is the
but,
one stent to really be
Completely go the other side.
over the other one, right? Yeah. So, and the other thing is, we think of these as two perfect circles within the IVC. Unfortunately, these stents,
Elliptical.
yeah, exactly. They're more like
Anything.
D-shaped. Yeah. So that's the IVC is going to be super helpful to figure out whether one stent is just totally crushed by the other. There's cross-filling between the two, and unfortunately, there's not really a whole lot you can do to fix that at this point.
Once they're crushed, right?
Yeah,
That's
once
true.
one is really crushed, you can try to buttress them with like balloon expandable stents and things like that.
Mhm, got it.
So, how did you decide on this? What size balloon is this?
12-0s. That's what I was going to ask too.
Yeah,
Did you
so,
do the 2/3 rule? Grab.
Yeah, and frankly, we're not really sizing to the 16 because I'm not worried about the 16 being to size. It's really the distal IVC.
Correct.
Good.
So 2/12s, D-shaped is probably about 20, right?
Yeah.
I don't really want to go to
The 16s or something.
Yeah,
'Cause
16s
that's
here.
how you can rupture the.
Exactly,
IVC,
yeah, because that's not a 30 millimeter IVC, right? So yeah, it just brings up a good point. Like you don't try to bring it
There you go.
to the two stents below, right? Otherwise, you will end up with a problem and rupture.
Yeah.
So I will also say that for this whole D-shaped concept that was mentioned by Rahul, there's actually in the CRAB paper that was published, I believe in a Circ, there was a lot of anatomic CT imagery that was actually talking about the forces associated with these D-shaped stents. So for those who want to read more about it, this is
Going up
definitely
again,
on
guys.
the internet to actually
One, count
understand
it out.
more.
So nominal is 4.
Yeah.
What is nominal, Dave?
Nominal is 4.
Slow.
4.
2. Yeah, we're just going real slow. Yep, just stay at 2. Let it conform. I always, I think also it's very important to go up slowly. You can see we're on the soft part of the wire on one side, so maybe push the wire up on the other side. Let me see. Yeah, there you go. So, whoops, okay, that's fine. And then that's 2, 3. Okay. And now 4.
Sorry, I don't think you
4 atmospheres.
Nice. It looks well expanded, and the wire is in good position. So I think.
Yeah, I think it's reasonable here.
Yeah.
So,
Would
you okay
take
with that,
these
Rahul?
two balloons also go
Yeah.
a little bit more proximal to balloon that, the other area between 10 to
That's
15.
floor side.
Would you
Well,
go proximal
just
here?
above, yeah. We can go
Yep,
above.
I'm going to hold the wire for you. Go ahead, you can go.
Yeah, there's some tapering there, so I think you want to optimize that whole segment.
Yeah.
All right.
Would you guys accept a suboptimal, 20, 30% narrowing, since it's a vein and they're going to be on anticoagulation with the idea that it may open up over time? Or how aggressive are you about creating a perfect picture with no residual stenosis?
No,
or
I'm
narrowing?
like you, Jit. I would actually leave something here because, to me, from no flow
Not
to
about
some
perfect,
flow is going to make them better. So 4. Okay, down. They're jumping forward.
I mean, that's true. I mean, it's a bigger luminal vessel, so hopefully that 20%
okay?
should not
We'll go
be
up again.
significant
I think
based
we're
on
okay.
We're good, right?
the
Yep, walking
flow
out.
and the flow dynamics of it. But yeah, I mean, here in this case, just
Yeah, I think
getting a little bit better pace will be good.
that would be my thought process.
Yeah,
is leaving
I mean,
a little.
Yeah,
Go ahead.
it's the same thing. The way I look at it is like an aorta, right? Like you
right.
need to take it up to the
IVUS guys?
the exact
Yep,
size of
IVUS,
the
right.
aorta. You just
Right.
run into problems. right? Trying to
Cyclocuff
make it look
guys.
perfect.
Right.
Yeah.
IVUS.
Obviously, some of this will be based on the IVUS, some will be based on the venogram. If we still see a lot of collaterals, then we may have to.
Do you want to take a quick picture to show how it looks and then do an IVUS?
Sure. Cindy?
So let's demag.
Yep. There you go.
Let's see the
Both
beautiful
the wires are back, but
Whenever you're ready.
oh sure.
Wow.
That's brisk. Yeah. So I don't think we need to take it
Nice.
up any.
Yeah, I think it
Yeah.
looks great there.
Yeah.
So going up now. So how important are the tributaries,
Wow.
Rahul and Ajit? There are times when you're ballooning, patient is having pain, you can't get rid of the tributaries. What's the story with that? I mean, how aggressive are you guys, Flora? Just to make sure the wire's not
In
back.
terms of
It is
not
back,
covering them,
Wire's
or,
back, right? Yeah.
or
No, in terms of getting rid of the tributaries when you're doing the stenting.
We're not showing the IVUS.
Let's go live on the
Yeah,
IVUS,
let's get
guys.
IVUS.
Over here. Yep, perfect. Thank you. Go ahead, I got the wire.
yeah, this is coming up the right common iliac. So we got good wall position there, right on the right. Going up here, we're sort of seeing the other stent crisscross.
There's
Oh,
the, yep.
wow.
There.
Look
Yeah.
at that.
It shows you how geography can fool you, though, right? I mean,
Yeah,
but again,
yeah.
that's the Achilles heel of this whole reconstruction is that confluence and where those stents are crossing. That's the key where we have to optimize.
I think Srini was exactly right. It's just the
Yeah.
confidence that's always the decision maker in this case. So
And then up
Beautiful.
here.
otherwise,
Yeah.
proximity looks
On the other
gorgeous.
side.
Yeah.
So we're gonna. So would you put a balloon expandable stent now? Is the
No, I think what we probably need is do we have like a high pressure? Like
Sure, we got Dorados.
Yeah, so like 210.
210 Dorados, please.
Yeah. So we'll take 210 Dorados and then see if we can just get that to at
Give
least
them 2 cup
16,
ranges.
18, somewhere
Yeah.
around there.
But to answer your question, I mean, I'm not
IVUS.
super aggressive. If the flow is preferentially in the stent over the tributaries, I think that's, all you need as long as the flow
Right.
is good.
Mm-hmm. So as long as you're seeing the flow in the stent versus seeing the tributaries, then you're okay with it.
Yeah, which is what we're already seeing
Yeah,
here, even with this
interesting.
stenosis,
All
with
right.
that narrowing.
Flora? Great. All right, guys, get ready with IVUS again. Start recording.
They're not showing it.
Up top, please. Thank
There you
you. Go.
Now we're going
Sorry.
from the left side, right?
Yep,
Correct.
now the left side.
So again, good wall position here.
Much better lumen. Still there.
Ah, yeah.
Yeah,
it's
that's
right
just still.
Right there, around 15.
Yeah.
And I
Okay.
think Rahul made a good point. You're going to need some high pressure balloons to
Do you
really.
have 2 of these?
Laura?
uh,
There you go now. There you go.
Yeah, to really pop
Very
this
nice.
open.
Very nice. Okay. All right, guys. So we're going to walk this IVUS out. Get us 2 10s here.
We only have 1.
1 10
10.
only?
Yeah.
Okay, we can. We need 2 though.
Do you have a-
Barry will have 2 10-0-20 Cordis balloons. Get the Optipros. Or does he have a Mustang 10-0?
This is where
there's-
dedicated balloons really make a difference, don't you think,
Yeah.
Rahul?
Yeah, so they have those high pressure balloons.
Which ones do you guys use then?
So there's the one I think most people remember is Conquest. There's also Athletis from Boston, and then but the problem with both of those is they only go up to 12. So if you need to do anything bigger than 12, then you're sort of stuck with it's the Bard's balloon. And I'm blanking on that.
Atlas goes
Gold.
up to Atlas Gold goes up to 14 and 16 as well.
we
yeah.
might
I
have
think there's a,
Atlas.
I think there's
Let
a
me go
20 as
check.
well. Yeah.
Yeah,
Yeah,
they go up bigger sizes, definitely.
Yeah.
Ask him if he has Atlas 10.
But you're right. I mean, this case is a perfect example of how venography versus IVUS can make a decision or change a decision in a way. So, I mean, when
Yeah.
you took the angiogram shot, it looked nice, beautiful,
Okay, he's got
excellently
Optipros. That should
reconstructed.
be fine.
But like how Srini and Rahul had predicted, is the confluence that's causing
by
all
40.
the issues, and the IVUS definitely confirms.
You don't have
it's
Atlas
very,
10-0s?
very tight.
Okay.
So in this case, Rahul, just to be a devil's advocate, do you think
Do
a
we have a
pre-dilatation
10-0-60 Dorado?
of the confluence would have made a difference?
It might have.
in this stent?
Okay, then give me this.
Yeah, it might have. Although, I think if we had, it may have. Yeah, it's hard to.
Isn't it a little
Yeah, no, it's
safer
hard to
though
predict,
to
but Srini,
dilate after the
what about your
stenting?
experience?
Yeah, no, I think Rahul is right. I mean, it's hard to predict. I mean, there's no date. It's a data-free zone. Like, do you need
Right.
to Usually, we pre-dilate only if we can't get the stenting. We don't pre-dilate to make it look pretty like an artery, and then do something beyond that. The other thing
Right.
too is veins, because they're fibrotic.
Bound, oh, thank
Correct. You have to break the bands. Yeah.
The other
See,
thing
that-
they're not. They're
Now,
relatively right. So you have to take your balloon to a much higher
It's kinda-
pressure. Get some kind of
you. There, right? Like it's not really the top of the stent.
you want to go a little further?
Yeah, we can go a little further. I think.
So I'm really aging
It's just
myself here
so
with the
surprising,
Optipros.
Like how different the angiogram looks.
Yeah,
compared
that's what
to
I'm
There you
saying.
go.
Remarkably
Yeah.
different. I mean, I guess that's the nature of having these
There you
open
go.
cell stents.
Yeah.
What you're seeing is all the flow through the actual open
cells.
cells, and what's happening at
Come
the
forward.
areas where the stents have not flared is not being
Mhm.
fully appreciated.
But that's what
Correct.
What's nominal, Dame?
That's why veins are tough, Ron, because they're not like arteries. They don't respond the same
Alright.
way.
Hey,
The way you
fix.
think.
Ready?
You think this looks beautiful, then you IVUS and it looks terrible, and then that.
And maybe we should just
Wish
get
to
out of the
agree.
habit of doing
IVUS.
post-stent IVUS.
Yeah. So the question exactly. The question is showing there is
We're gonna
blood
have to go
flow.
like
Do
12
you
or
exactly?
14, right?
Do
You wanna go to
see
14?
the blood
Yeah.
flow?
Yeah. So technically, you do see blood flow. You just don't like the inside.
Yeah.
12.
Problem is they'll come back
Okay.
from.
Okay.
Leave it up a little bit.
I think
good.
that's
He's
a
feeling
very
it.
important point. So it defeats the whole purpose
come
of
back
doing
a
a
little?
reconstruction when you
Yeah.
create another nidus for a DVT, I guess you could say.
Yeah,
So
and
you're
the
definitely
other,
right.
the other thing, again, he's not under general anesthesia, which is actually somewhat helpful because he started to feel that.
There you go.
So you sort of know, okay, like don't keep pushing it, right?
Yeah.
I'm surprised you guys are going more distal and not more proximal to get the middle of the stent. The middle of
Well,
the
we're gonna
balloon
go all the way.
over
Going up
the
again?
stent.
Yeah.
So we're
Just
going
needs
up
really
to
just at that overlap segment.
You can see it's narrowed as you're inflating your balloon still, you know what I mean? So this is
Yeah.
really,
so we're at 12 bilaterally.
Yeah.
You ready?
and if he's doing pain, then I think you're okay, you know? So.
Yeah. I guess we could
Yeah.
do the upper segment too.
Yep.
If you want to do it
I'm just going to push the wire up a little bit. Okay.
These are 9 balloons.
10.
10.
10
Tens,
balloons.
yeah.
Nice.
Oops, too far.
Right.
But we, Rahul and I
He's
have seen
picking
this
on my
in-
glasses again. He's so mean. Ready, go up.
Yeah, sorry,
Well-
Srini, you were saying.
Vishal,
No, I was
please reprimand Roman for me.
At 12.
12. All right, 12 atmospheres.
Well,
Okay.
looks expanded on the balloon aspect for sure. So
Yeah.
All right, now we get the IVUS. Cycle of cuff, guys, for us.
Rahul, how often have you had to kind of support the
Laura,
confluence
bro.
with balloon expansion in your?
It's been a long time since I've had to do it. It's not very often because there's not a lot of options, right? In terms of, what
Sizing.
I mean, here you'd need at least a 16, balloon expandable stent, right?
Okay, DSA.
Yeah.
Yeah.
Mhm.
Even a DMAG.
Let me just shut
Adding
it
also
in.
a fourth
Fourth.
and fifth layer
There
of
you go.
stents.
Uh-huh.
yeah, because if you do bilateral balloon expandable, then you can do one of the. All right.
Yeah, that's
I
another
guess,
see.
thing.
I guess it'd be only fourth.
Look at
Guess it'd
this.
be only fourth.
Yeah.
Still down below a little bit.
Yeah, I mean that's part I think because there's tension on the vein from the 10 French sheath
Okay.
in the external.
Got it.
Yeah, and we can run it up. We can run up the IVUS on the right
Yep.
and see what's going on in the external. But that looks like actually the problem is there might be below where we're.
But there's
stenting.
not much. I mean, even
Oh,
if it
there's-
looked the same, wouldn't
Yeah.
you'd probably leave it,
Yeah,
right?
yeah,
I mean, there's not.
Yeah.
It's not worth restenting.
Yeah, we're not going to extend the stent. I don't think we're going
And
to.
I think
Yeah.
it's a little bit better flow on
Yeah,
the
that's-
left IV
this-
common iliac vein as well, suggestive that there is a little bit of reflux going in, suggesting it's opened up a little bit better than before.
Yeah.
If you see a little bit
IVUS
of
guys
backflow
up
on the
here?
left
You mean
side, so
on the right side, you mean?
we inject from the right, on the left side. So if you see, there's a little bit
Yeah.
of backflow on the left, expecting that the
But
lumen is opened
this
up.
also looks
Looks
different
pretty
than the
good.
first one because
Correct.
you have much more flow going on
Yeah.
the right side.
Right
of
side.
it,
And there it
the
is.
yellow barrel.
This looks great so far.
Much better.
Yeah.
Much
Right there.
better.
Yeah,
Much
much
better.
better.
It
Much
was
better.
very compressed.
All right.
Oh,
Okay.
yeah, definitely.
All right, now we'll do the other side.
And if you look at
then-
the size, I mean, think about it. IVC 18 to 20, 22 millimeters. Common iliac veins around 16. Externals
16.
around 16. And common femoral veins around 12. So if you look, that's exactly how Rahul sized it with you guys. So.
Yeah.
Yeah, I mean the 16 is probably a little oversized for the right, but you kind of try to keep them to match to size. I don't want to do like a 16 and a 14.
Yeah,
Yeah.
no, agreed. I could probably create a at that point.
Ready, rail? Okay, we did. We're gonna go live on the IVUS on this side too, guys.
Yeah.
Cuff pressure is good. Yep.
This is the left.
Okay. Going in. This is where I'm just hoping that it doesn't collapse
Right
from
there.
one side to the other.
No, it looks
Nope.
very nice.
Yeah.
Eh,
Right there. It's, yeah.
But you didn't
Left
inject
is-
that side yet either, though, right?
yeah, we didn't inject this
TK?
side though. Yeah.
So let's inject this side. Okay.
That's this, yeah.
Work it out, brother.
So now to decide between a venogram and an IVUS.
Yeah.
Where does the truth lie? Somewhere in between.
Yeah.
But
Yeah,
if
I
the
think it's a
flow
hard
is good.
decision. Yeah.
If the flow is good, I think it's unlikely to
Yeah.
thrombose on AC.
Yeah.
Well, he's going to be on chronic AC for sure. You know.
Ready?
Yeah,
1 second.
yeah, definitely.
Okay, Cindy. Not that good.
Yeah, you can
And it's
see
Not
the,
the same as the left. Not,
Yeah.
not the same as the, right.
right.
Yeah.
Is the left also from an assist or was the
Yeah,
both
same.
both
Both are
both
from
assists.
both were assists?
Yeah.
Okay. Yeah. Then there's definitely a marked flow.
Yeah.
We'll do it again one more time because we had a little bit of I guess we didn't prep it. Let's do one more time. One more picture. Because I didn't prep it, Roman, so we'll do another one. Yeah, it's definitely a little bit sluggish.
A little bit slower.
Yeah.
And you can see you've got reflux into your internal iliac vein.
Correct.
Yeah.
Lumbar is open still, and it's refluxing to the other side. So you got some level of
Yeah.
hemodynamic
I mean, the The
Yeah.
next step would be to take two 12 high pressure balloons and just try to really slam it open,
Yep.
right?
Let's get two. You have two 12 Dorados.
It's also a much bigger iliac vein on that side too.
Yeah.
We don't have any other high
But
pressure. We have Atlas.
The
or-
reflux is concerning.
Let me scrub out for a second.
Yeah, of course.
Is that going down that middle sacral vein through there, Ajit?
No,
I think so.
What is
I think so.
Yeah, I think
Or
so.
might-
Just a hypertrophied one from the chronic IVC occlusion.
Yeah.
This is why veins are tough. They're tough
Yeah.
to treat. Veins are not easy, you know? They're just not
Yeah.
easy.
Well, this is why I think it was good we didn't, we minimized how much we overlapped all three stents, you know, because otherwise this could be an even longer segment that we have
Yeah.
to deal with.
Yeah.
I was going to say oversizing and overlap both could have been detrimental, worse than what it is right now. Because if you oversize it, like Srini is talking about, you really create so much compression right there that you not have enough space to get the luminal gain and flow. So I think the sizing becomes important, and Rahul, of course, size it perfectly fine. It's just the way the anatomy is. We just have
Well,
to probably postulate it.
It's just that distal IVC hasn't opened up to 20 millimeters, you know, that's why
Correct.
when we ballooned, even with just the 10s, you know, the patient felt it because
Yeah.
we're stretching the adventitia, so it's still constrained a little bit.
Yeah.
Yeah.
We're just
I
waiting
think-
for the
When's the next
waiting for the
ACT?
right balloon.
When's the next
So
ACT?
let's say, Rahul, I mean, hypothetically, we do it, we try our best. We still have whatever we're looking on the left, not as impressive per your satisfactory level. What would be a next step? Just
All right.
how would you
so
follow this patient? Yeah.
We were able to find two PowerFlex 12x2 in our pediatric room. So these are post-kill balloons.
Oh, my
so
Lord.
it should be fine.
What an oxymoron. But bigger balloons, pediatric room. Huh?
Well, he does these, I think, for
like a
for the
10
pulmonic
centimeters.
valvuloplasty. So should be fine.
Yeah, you know, honestly, there is obviously significantly improved flow. He's going to be on AC at some point. I think we're going to have to sort of just leave it, right?
Right.
Yeah.
So I think that's a good point. So determination on angiographic, how the flow is also will help us guide decision in this, whether to proceed further or just to stop right there and just follow the patient medically. So I think that's an important point. I mean, same thing, I guess, with our interventional cardiology, how we do IVUS in a corneas and peripheral, the sizing in the vessel looks worse or better than what it is. And sometimes we make a decision based on angiography and our results and our feeling experience and say, okay, it's going to be fine and we're going to be okay with it.
Yeah, but the problem is with the reflux back into the external vein. I think you clearly have a significant.
No, definitely.
So I think you have to balloon this.
No. I definitely agree. We're just trying to determine our endpoints, saying, of course, we have to balloon it and try our best to get the best result possible. But we're just trying to get onto what are
What's
the
nominal
endpoints we're looking for, both
type of-
angiographically and IVUS.
That type of clarity we really only have it in the coronary world.
Right.
Which is used for the utility of IVUS.
Correct.
PCI. You know,
I know
with-
people have tried to use. Oh, go ahead. Sorry. Yeah.
Yeah, no, I mean just saying the same thing. Just like with IVUS, if you have leakage rates of in-stent
Right there.
thrombosis,
Everything
which
is lesser.
it's a huge
Correct.
objective
Six,
measurable
guys?
marker. And this is based on randomized controlled trials, meta-analyses. I mean, we know
What's the rated burst?
It works.
objectively
Rated
that
burst
IVUS
is?
affects coronary outcomes. But with these, with the
12.5.
SFA intervention, the tibial
Where did the
intervention,
stents end?
the
Is it
veins,
higher?
and so forth,
What's
it seems
Ready,
as
go
though like
up?
a little wishy-washy. You know, that if you have some
What's
anecdotal
rated
data
first?
that says that if you have some degree of persistence of
So 6. You want to go to 12?
Residual
Yeah.
lesion.
residual
8
lesion,
rated
that
burst.
you should do more, but
I go to
you know,
12.
it seems as though it's not so very
At
clear
12.
that this
Correct.
is a numerical value that you
Down
must
together?
achieve to then not have
Maybe
the
go up a little
suggested
bit?
associated poor outcome.
Agreed.
So I say
Like
we don't
some
IVUS after this.
No. We have to.
Well, there's nothing else to do, to be honest.
Correct.
You
That's
know,
what
it
I'm
wouldn't
trying
change management.
Yeah.
to-
And
yeah.
I do think with time, this will be fine and it will probably open up.
Yeah.
Sort of weird. Like the stent as you go up, the balloon stent's getting narrower.
I know. Oh, that looks weird.
Ooh. Yeah, eccentric.
Down.
Right more than the left. Or it's just an overlap, the way it's...
Yeah, it's just the way it's overlapped.
Yeah, the
right?
way it's oriented. Correct. Exactly. Looks as if the right expanded
Wish
better
we
than
got
the left. It's
higher,
just
right?
behind it.
Mhm.
Like the middle of the balloon over the overlap.
Yeah.
Yeah.
Get together again.
Pull it down a touch.
No, he did the distal end first, and now he's pushing up.
Yeah. I think it's just the way it's.
It's
moving up to-
very
to 10.
fibrotic, yeah.
Yeah.
Okay. 12 or 10.
12
10.
number.
12.
Wow. Waste on that.
All right.
Let me see. Well,
Probably
Yeah.
confluence on the way out, you know, truthfully.
Yeah, we'll hit the
Yeah, one
combos
more
right
time.
here.
Yeah.
Right
Yeah,
here.
just where it was really tight there on IVUS.
Yeah.
Since we dilated
A
everything.
little bit further up, you think?
Yeah,
Or
maybe.
Yeah,
Yeah.
just to
kind of going up again.
Because it was the left side, right?
12.
12.
yeah. It starts just below the confluence. Actually, correct. Yeah.
Now, another question. Let's just say that it looked like from the IVUS that the right side was the IVUS and the angiography, the venography, that the right side was better off. If the left side, which is the side which seems to be still with some residual disease,
this one's not out all the way. Oh, you went to the left
that
side,
side goes down. What is the associated likelihood that the right side is going to suffer the same consequence? Like, can the left side close without the
Much
right
better.
side
A little better.
Yeah, that's
being
better.
sacrificed?
Definitely better.
What,
All right, let's do
is that the natural progression that if the left side goes down, likely at the level of the confluence and at this overlap, that the right side will also go down?
So, in my experience, it's usually if it's the problems here, like because of crush, it's usually one side that goes down, not both. Yeah, if the problem's up higher above the confluence, then it's usually both that go down.
Right.
So,
But
all
that
right,
being
guys,
said,
IVUS
if
live.
the left side goes down, would you bring the patient back to even work on it again, considering how much work it was this time to kind of open everything up? And would you just allow them to survive, considering how they started with the IVC occlusion and the right and left side that was just simply diseased? Would you just leave them with just the left side down?
I think it depends on.
It's better.
It's a little,
Better.
well, better.
Yeah, better.
See, this is when it's good not to have good eyesight.
You're squint. So I think we're good there.
I think we're good.
Yeah.
All right, guys. So I think at this stage, what you want to go up further, Flora?
We can. Yeah.
Yeah. We'll keep IVUSing, guys. IVUS live. Thank you.
Yeah, I think proximity looks good.
Yeah, approximately looks good.
Very nice.
Good. All right.
Cool.
Well expanded, opposed.
All right.
We just take the wire out too.
You want to take the wire out?
Yeah, I think we
Okay.
need it, right?
Good. Look, we're going to do IVUS on the other side.
Sure.
Yep.
I got it. Yeah, it depends. To answer your question, should we, if it went down, would you bring it back? I guess it depends on how symptomatic they were. And then you can try to work at it. And then maybe at that point you can consider putting the the balloon expandable stents if it's still really crushed.
So you won't put them now because you're not sure it's going to go down.
Yeah,
That's basically the
exactly.
reason. Okay.
Yeah.
Got it. IVUS live, guys. Good. There you go. Much better.
Yeah.
Much better.
Too vast.
The right side is very impressive.
Yeah.
Left side is not, obviously. Let's attach it.
How would you monitor this then? Would you get a CAT scan or just?
Yeah, so we do duplexes, try to see up as much as you can. You can see, you're not going to be able to see the middle. You want to take this out?
Mm-hmm.
You're not going to obviously see the middle, but you should be able to see the intrahepatic and the suprahepatic side with ultrasound, and then the lower iliac. The vascular lab here is actually quite good, so they're pretty good at seeing this. But yeah, you can also follow them with CTs.
Yep.
Nice. Okay, ready, Cindy?
All right, can we see the angiogram, please? You can take the IVUS out. Yeah, perfect.
Yeah, some of that's respiration, but yeah,
Much better flow.
yeah, that looks much better. Yeah.
Okay. I think if you guys
Very
are
nice.
okay, I think we call it a day, huh?
Yeah.
Everything looks good.
Yeah.
Cuff is
Yeah.
good. So I mean, any further comments, Ajit? I mean, in terms of anything else? I mean, so you agree not to stent the bifurcation at this stage?
No.
Okay.
I think I think there's already a lot of stent in a kind of constrained area, and I think it opened up. The flow is good. To be honest, I'd probably just do one high pressure balloon and just even leave the picture before we had this. So
Okay.
so I think this is good. I think with AC it's going to be fine.
Fine.
I think I've seen over time the vein kind of conforms to the native stent size. It does tend to stretch. So I think this patient's going to do fine.
Perfect.
Cool.
All
Yeah.
right. Well, thanks, guys. I guess it was a great demonstration. Thank you, Rahul.
Yeah, of course.
And thank you, Ajit, for taking your time today and helping us learn. And thanks, guys. Srini, thank you very much. I know you're super busy in Florida. Much warmer than us here. So enjoy.
It's cold in Florida.
I
Look
don't
at
know
him.
why he's wearing a sweatshirt. I was going to say, why is he wearing a
Well,
sweatshirt?
there too.
He wants to be a part of the team. He's like
Yeah.
the camaraderie right there.
The air conditioning's on.
Exactly.
Yeah.
The air conditioning is on. Rahul was saying you might be on the beach. So that's the thing. Well, thanks, you guys.
Thanks, guys.
All right, so
Awesome.
we'll see you next week. Next month.
Next month.
Thank you.
from
All right, guys.
Thanks,
So
buddy.
again,
Now, how do
everyone,
you
thank you
close
for
these?
joining us on this really excellent, very complex IVC reconstruction case. Really fortunate to have such powerhouses in the field to join us and to teach us how to do these very, very complex and not very commonly seen cases. That being said, this is a great time today, great discussion, and we look forward to seeing you again next month from Mount Sinai Fusa Heart Hospital on February 26th.
Yep.
Take care and enjoy. Have a great day.
Have a good day.